afternoon, everyone. Welcome to this session of by CAVI or strict valve session. As you know of, the isolated severe tricuspid regurgitation surgery is a very high risk. Usually the surgeons, they shy away, especially if you have an RV dysfunction. For this reason, there are many platforms now to percutaneous intervention on the tricuspid valve. And the trick valve really opened another horizon for treatment of such cases which are not suitable for most of the devices available. So I have the co-chair with me, Dr. Nabil Ismail, and faculty panel, Dr. Salim Asiri and Ahmed Al-Shahri. So I'll let the microphone for my colleague, Dr. Nabil Ismail, to introduce our first speaker.
So without further ado, let's start with the first lecture. Will be done by Dr. Sondos Samargandy from Prince Sultan Cardiac Center, and she will present a real-world experience and 2-year outcomes of trick valves. Dr. Sondos.
Thank you for the chairman and the panelists. So can we have my slides, please, on the screen? So I'm going to make it more practical and understanding and clinical, because we know, I mean, that's the title that I was given. If you can TAVI, you can CAVI. So we know TR is bad. The more advanced we have the problem or left without medical intervention or technical intervention, the worse the outcome. And then unfortunately, the window is small if you look into it from another perspective, because usually we think they're good, but they're actually not good. So recently they have, FDA approved balloon expandable and asymptomatic AS. So are we going in the same track now and treating TR before it, become very symptomatic? We have been proposing multiple algorithms to choose a device selection and to help you going with that, and I'm happy to declare that the focus group that came up with this in the state of the art are now coming up with the updated version of it, and hopefully we will see it within the upcoming 1 year. The available, this is one of my slides from last year in the EuroPCR, that we have at least now at the time the trick valve or a tier, and we have also the valve replacement coming up hot in our tail in the upcoming few months. But at the end of the day, your target is quality of life and improvement of the symptoms. So this is a case, 63 years old lady, multiple medical problem, already had a surgery with mechanical mitral valve, been having multiple admission for right-sided heart failure, acidic TAP every 5 weeks. Her gap was like 2 centimeter or 20 millimeter, giving us she's not suitable for TIR. We did a CT for her showing that it's suitable for a size of 25 and 35, and keep in mind, usually the eligibility of the CT is 6 months because those patients are very dynamic, and we have been discussing her, she's not for surgery. We went on and we did the procedure, and you can see we done very great with this patient, and you can see the date is 2022. Patient was seen just in December, ejection fraction 45, no admission in the last 3 years from going in and out of hospital every 1 month. Second case, same dynamic, same age. Already they opened the chest 4 times with multiple, with the rheumatic mitral valve repair, going in and out. Multiple heart failure admission. She came and discussed her surgery in the beginning of 2023. So we had that treatment available, but unfortunately she was not referred until October. So we're talking about 10 months of waiting. By that time our PA pressure went up, our TR is bad, already in CRRT and in and out of bacteremia. Though she was suitable to do an intervention with her, but I couldn't do it because already the boat has sailed and the ship has sinked. So early referral, early intervention, you will have a better outcome, but extreme late referral, you will have a bad outcome because you cannot do anything at that time. And your patient selection is very ideal candidate. Don't wait until it's too late. Go with a patient who are in a good condition, good LV, good to some extent RV, and no pulmonary hypertension. So another case who is in 75, who had a pacemaker due to complete heart block, Again, the same scenario, right-sided heart failure admission. PA pressure was 50, we have severe TR, the LV is good, MR is moderate, so because you cannot interfere with the left side, right side without intervening or fixing the left side. So this is like a quick run through the case. Usually you go and confirm the position in the jugular because this is where you're going to put your stiff wire. It's a 27 French, so you can do, and you can see out of the back, there is a face mask of oxygen. The patient was awake during this case, and you can see the pacemaker running in the leads. So this is a proof of concept that you can do the procedure in lead-related TR or, a secondary TR. So now we're positioning. Your aim is, as you can see here, the PA catheter, if I can do here, your aim is your belly to be above it as a fixation, and your end should be in the upper part of the junction of the RA and the SVC. So you can see some mobility, so take that in consideration when selecting who of your patient will be awake. You can see some impinging on the lead, but so far we had a technician with us in the room that showed no problem with the impedance. Now with the positioning on the inferior, and this is where it's become tricky. So you can see one of the the issues that I had in this case, that the patient was awake and there were multiple mobility. Yet I had the grace of God that the hepatic is a bit big, but the junction was not big. So something, balance something. This is where your skirt usually be, and this is what you don't want to happen, that to cover this part of the skirt, to cover the hepatic vein. Usually the junction should be reasonable, but in my case it wasn't. So it's acceptable to have 1 centimeter inside of the right atrium, and your super stiff is there, and this is where the TE may be helpful to tell you how much of protrusion inside of the RA you are, but to some extent I didn't have that in this case. So I should have accepted this position, but I was aiming for perfection, and sometimes less is more. And we have seen in the live cases in the last 2 days, when you go for more, what might happen. So we're trying to position, and the aim here be very slow. The skirt basically is coming from here to here. I have some, partial coverage, but it's fine. If you are in doubt in the view, you can go for a lateral or orthogonal view to help you. Here you can see the valve is dripping in. No, I have to recapture. So I'm demonstrating now that you can recapture and you reposition. We went up a bit, but it was too much protrusion. Okay, control. So now this is one of the problems that I had in this case. There was no coordination between me and my second operator. So we had issues. Patient was moving. It was not under GA or like TEE guidance, and the position or the junction it was short, and I didn't have the proper view, and there was some lack of coordination between me and the second. Then you can expect a problem is going to happen, and that's what's going to happen. You can see here, we started to drift down and more down, but we didn't have a major problem because the hepatic vein was good and open. So now we have a significant paravalvular leak, and you defeat the purpose of having a second valve. So we put another valve here. You can see it's very obvious, like we are the whole way in, and you have a product. That injection tells you that you have a significant paravalvular leak. And now you already lost the whole concept of CAVI. So we put another valve in an upper position. Okay, patient already a reason for AF, and she's having anticoagulation. And this is what you want to see. You don't want to see any jet going up to the superior, and you don't want to see any jet going inferiorly to abolish the TR or regurgitant jet. So we have, and this is one of the prognostic elements. If you have a V wave that drops, that's a prognostic element. It went from 70 to 36, 50% reduction, and she was discharged. You will think, well, this is the second or third time it's happening. Do you have a follow-up? We have a 2-valve in the inferior. I have 1 year and a half or 18 months. The patient basically asymptomatic with good, and we have some remodeling of the TR itself. And this is what you want to see, the drop in the LV, and this is what you want to see, no jet up, no jet down. So we have demonstrated by the data that it's been improving the quality of life, I just show you there's some, remodeling even, but it takes some time. This is one of the cases that you can see there was a gap here, but as the time went by, 6 months, minimally speaking. What is our experience? I just showed you the case with a pacemaker or an ICD, and the question, can you do it in a post-tricuspid repair? Yes, you can, we have done it. Can you do it in the element of TS, not pure TS? Yes, you can, providing you have a good large V wave. Is it possible to treat only one? Well, sadly, regretfully say, I have attempted that in an indirect way, but just we fixed the inferior, but the superior vena cava started to migrate up for multiple reasons, and it reached up to the jugular. And then the patient has an upper lymphedema. He was dry as a stick in the lower limb, but upper lymphedema, so I had to do another one up. So it's feasible, and as I said, so at the end, and I'm concluding my talk, we talked about this is a palliative. This is just quality of life. Why are we doing it? It's inexpensive. It is. But at the end of the day, if you can read Arabic, it just say, وَلَكِنَّكِ صَنَعْتِ لَنَا حَيَاةً أُخْرَى. You have developed for us a new life. Our lives has changed. Not only his life, the patient's life, but all of us. This is what, and our Father is now coming with talks and laughters. That's what you want to see. That's what you want to hear. And by that, I conclude my talk. Thank you, everyone. We have a 5 minutes for question, if any.
Go ahead.
Thank you. Very impressive presentation. I just have a question. We actually had a case where we used trick valve, and then there was failure of the inferior vena cava valve. Now, what is your strategies to fix it? I mean, there is a lot of rigor, and what would you do? Would you put another valve? Would you put another like self-expanding, or balloon-mounted valve, otherwise than the trick valve itself? So what do you do in these cases?
So it depends on the mechanism of failure. There are reported cases. There is a case report that has been presented that the whole inferior vena cava migrated upward. So you had lots of involvement up. Going too much up or too much down, same concept as TAVI. You're going to have a paravalvular leak. And then you're going to lose the whole notion that what you want is to abolish the regurgitant jet to the liver or the kidneys. So in my case, I put another valve because mine descended lower. And therefore, I sealed it and I put it. I don't know if your valve went up or down, but up it has been reported. They put a second valve, and down I have done it and I put a second valve.
It was 3 months later.
Did it descend, or is just the valve itself?
Failure.
So first of all, just make sure it's the same concept, any bioprosthetic failure, what was the mechanism, is it an infection or something, and you treat it the same way. But if it failed with now regurg, I think you can put safely a second device. You don't need anything, even the patient, when I did my case, I put another valve because I have the landmark, I did it under conscious sedation. He can be awake. But since you struggled with the first, I think you can do it under GA with TE guidance for positioning and understanding more what's going on. And then you can use the pigtail to put it in the RA and have an injection, confirmatory injection to confirm. If you don't want to go from the leg axis, you can go from the jugular and from the transjugular, and then you can do your injection from there with a pigtail. So I think it's safe to put another device, providing there is no active infection.
Did it embolize or late embolization?
The
or
valve.
Just failure of the
Failure in
valve?
what sense?
Central regurg?
PVL.
Not BVL, central regurg. you said.
Central.
Central regurg.
The other part is the sizing would have issue, or with the pigtail coming in and out has done an injury. It's hard to tell until you see the images. But I would advise, make sure there's no infective endocarditis, then go for the next pet. But I think it's fine, you can put a second one. You can, but again, I don't know the time of the CT that you have used in order for you to define the size of the inferior. If you lapse 6 months, I would advise to repeat the CT. And if there's a kidney issue, I would advise you can go with an MRI. And the company, and it has been, kind of validated, use MRI as a sizing. So you can go, that MRI maybe can give you also hints of what's going on with the leaflet or so. Yeah.
Because it's a
CT
low
also.
pressure area. Amazing that the valve degenerated quickly. You wouldn't expect it all. Yeah.
Yes. Because by the default of 2 years, which was presented in Euro PCR 2024, I think they had only one case, so related to the device itself, not in other places, yeah.
Thank you, Dr. Sondos. I think
Thank
the
you.
next